the next speaker is from Denmark. He's actually not so relaxed because he has to catch a flight this morning, maybe even, so he's in a hurry. So that is Professor Andreas Kjaer from Denmark, from Copenhagen, University of Copenhagen. And you are also at the Institute of Nuclear Medicine in the hospital and clinical physiology. I saw your CV also. Yeah, same story, a real expert, so many papers. Also, I saw many patents. Thank you and for being here. And please, we look forward to hear your experience with PET and nuclear medicine in cancer immunotherapy.
Thank you very much. I'm happy to be here. And I understand now I have at least half an hour. No. So I'm from nuclear medicine, and I think what we just heard was a really good background for what I'm telling about. So this is all about nuclear medicine, theranostics, and immuno-oncology. So I would just start with why are we so excited about molecular imaging? What is molecular imaging? Molecular imaging is really a non-invasive biopsy. So we very often want to look at the phenotype of cancers, but we can do it non-invasively. So a non-invasive biopsy or pathology. Why is it good? I'm not saying that we shouldn't make biopsies, but why does it often beat biopsying? That's because we circumvent the sampling error. If you think of a patient that is going to have her septin and we look at whether HER2 is expressed, you don't know, and we know from imaging that it's not necessarily the same in a primary tumor, in the metastasis, over the course of disease. So you only get a little bit of a view if you take a biopsy and do a lot of evaluation on that. We get the whole picture. And I'll just give you an example up here. This is a cross-section through the liver. The black dots is something we are looking for with an imaging marker, and probably if you took a biopsy, it would be taken where the red arrow is, so that where the lesion isn't that avid. But there's another lesion that is much more hot, and that's maybe the correct readout. If this was something that relates to your prognosis or how aggressive the disease is. So the advantage is we get the whole picture. It's 3D, it's whole body. So if you want to see if there's a hot spot, you haven't overlooked it. If you do Gleason scoring by biopsies, we all know that it's not the same you get even if you biopsy very close with a couple of months between. If you do imaging for the same marker, you really get the whole picture. So that's why we're excited about moving a lot of phenotyping to imaging. The question then comes, how good is it? And it's really good. And why shouldn't it be? We all believe in immunohistochemistry, but that's also just an antibody. We can radiolabel an antibody and you get the same readout. So it's no less precise and you don't have the sampling error. And what we did up here is actually that we have had a group of patients where we exactly knew where a biopsy was taken. We then did, these were neuroendocrine tumors, aggressive ones. We then did quantitation of the gene expression by PCR, and then we correlated it with the avidity in that particular lesion where the biopsy was taken. And here you can see, if you're not cheating in biology, I think that's as good as it will get. There's a perfect correlation between the molecular readout in the lesion and what we did image-based. So it works. And for many years, and we looked a lot into different predictions, and we just heard that it's very important to know what is the likely outcome of a patient, and we just showed that you could stratify really good if, and this is the sugar analog, the workhorse still in PET, FDG uptake, the higher it is, the poorer prognosis you have, because this is a measurement of the aggressiveness, of the Warburg effect, and so on. And how good it is relative to the way it's actually done. So on the left, you see the image readout. To just say we stratify these patients in the avidity on the scan, then you get a hazard ratio that is quite high. On the right, you see what we actually do. We classify these patients into WHO grading that is based on proliferation, which might be very good, but from some sample you have from some biopsy, then you do a calculation of that, and then you classify the patient. I would rather be classified according to the left scheme relative to the right scheme. And the good thing is it's moving in this direction. And why is it? It's because we don't have the sampling error. If we say there's a hotspot, high uptake somewhere, it might not be the place where you would do your proliferation readout. So it really works. And FDG, the workhorse, it's a sugar analog. It shows aggressiveness. So that worked. We were happy for many years. It worked very well. We could classify patients. We could see whether therapy works. A patient up here with quite an amazing response. So everybody were happy. But then we started doing immunotherapy, checkpoint inhibitor therapy. And then the problem arose because, unfortunately, activated immune cells, T cells, also take up FDG. So now you have part of the immune system, you have cancer, and you have a readout that cannot discriminate between the two. So that's why, and what's shown up here is just a patient that actually responded quite well, but where you have in the number 2 from the left, pseudoprogression, basically because you get a flare, you get immune activation. So it didn't work. So we had in the community to look into something else, and this is just, say, phenotyping. We are looking at the immune system here. And then, and sorry if this is too simple, I'm sure you all know about it, but just wanted to remind you about, again, we have basically our own immune system fighting cancer, but unfortunately, in this connection, good for the rest of the body, we have the checkpoints, PD-1, PD-L1, that basically stops the immune activation, the immune fighting of the cancer. And then, of course, the immense breakthrough with checkpoint inhibitors was the idea that not going after pushing on the immune system, but just removing the foot from the brake, and then you got really the activation that it worked. But we really want to be able to know what happens up here. And as I said, both the T cells and the tumor cells will contribute to FDG avidity, so we can't use that. So the obvious thing, of course, to go for is, on one side, to be able to visualize T cell, so infiltrating T cells, and the other side, as also done with biopsies, PD-1, PD-L1, as that's the target for the checkpoints. To put it another way, this is just showing 2 breast cancers up here. The one on the left is a so-called hot cell, a lot of T cells, the dark spots you can see. On the right side, a totally cold cell, tumor. So if you come in with checkpoint inhibitors, of course, there's a difference in how well they will work in these 2 situations. So we started many years ago working with imaging of these 2 things, CD8, also CD4 actually, and this is just a very early image where you can see a uptake in the lymph nodes, in the spleen, not surprising, but also in a tumor, in this case a hot tumor, where you had T cells, that's why there's a CD8 signal. And did this work? These are a collection of many different tumors that have different degrees of how hot they are. So what you see, I would just ask you to look at the G panel. What you basically see on the x-axis is the max uptake. So the higher number, the more CD8 or CD4, and the more T cell infiltration, so the hotter the tumors. And on the y-axis, you see the relative tumor growth in response to a PD-1 antibody, a checkpoint inhibitor. So what this tells us is, if you have very hot tumors, you also have a very good response. If you have cold tumors, you have a very poor response. They continue. Not surprising, but of course, very nice to show it non-invasively. This was across cancer types, but it also works within cancer types. So even this is cell line-based tumors. If you take different of them and repeat experiments, then you also get this connection within a tumor type. So we were quite exciting, and of course, this is something that has been taken much further. Also on PD-L1 or PD-1 imaging, we did imaging. What we did was actually that we did site-specific labeling. You get a much higher uptake instead of random labeling. And you can see some of the initial animal experiments where the tumor is marked up there, and you have a much better signal when you go to site-specific labeling. And again here, these are non-small cell lung cancer models of different hotness, if you want, or the different PD-L1 expression, and you can see the tumors. Unfortunately, I don't have a pointer here, but you can see the tumor to the right at the cross-section. And it worked well, it correlated well with immunohistochemistry. Why shouldn't it? After all, it's still an antibody that binds to the same target as whatever antibody you have for your immunohistochemistry, and it also correlated with flow cytometry. So we now are able to visualize both these sides of what's going on or what is relevant for immune oncology. Then, of course, how do we do bad days to good days? So how do we turn cold tumors into hot tumors so they are it will be more efficient to combine it with checkpoint inhibitors? And one of the concepts that is used is radiation therapy. It might not be at the dose you would normally give. It can also be at a layer. You expose epitopes, you induce an immune response, and then you can come on. And I can tell you, I'm heavily involved in all targeted radionuclide therapy or many of these testings, and there isn't any of these targeted radionuclide therapies that are not tested experimentally in combination with checkpoint inhibitors. So it works. What you see here is basically that you get a higher signal, both CD8 and PD-L1 in this case, when you do, in this case, we did external radiation therapy. But now it becomes interesting because we can do this with external radiation therapy. But I hope you all know, and we're sitting here at Novartis Center. Novartis has the two first compounds of targeted radioligand therapy, Pluvicto and Lutathera. My prediction is that external radiation therapy in 10 years will be almost entirely replaced by targeted radioligand therapy. So radioligand therapy is radiation therapy that you inject, then it seeks out the tumor, it sits there, it's excreted from the remaining of the body, and then it sits there for days and irradiate with a short range, either a millimeter if it's beta or even down to a couple of cells only if it's alpha therapy. Extremely efficient, but also a concept that can be applied to disseminated disease. Disease where you would never go for external radiation therapy because you would kill the patient by radiation before you would have an effect on this whole tumor burden. But there's no such thing as a too disseminated disease. There are limitations still, but in theory, you could go for it if you have targeted radionuclide therapy. And this is exciting in connection with making cold tumors hot. Why? Because now you do the same on the whole tumor burden. It's not the primary. I know there are effects that can draw that you activate the immune system, but why not make a direct induction in all lesions you have in the body? And that is what you're doing by irradiating all parts of the cancer cells, even those you didn't know were there, because they are micrometastases. So this is a concept heavily combined with this. And where are we then today? And these are not our data, but of course we are not the only one working with them. It has been translated clinically. So there's an anti-CD8 minibody PET available for clinical trials. And what you see up here is to the left, FDG avid melanoma metastasis, but in the middle, you see that they are also CD8 positive. So they have a lot of T cells in them. And then in this case, you see, if you compare the CT on the left to the right, that there was a complete response. So it's out there, and it's included more and more into clinical trials. If we look at the other part, then this is an example of an anti-PD-1 labeled marker, and this is a case of non-small cell lung cancer. And what you see is on the CT to the left, you see two lung tumors, one in the upper left and the other one to the right. And you can basically see that the readout in the middle panel is totally different. The lower one is hot, highly expressed PD-1. The upper one is not expressing it. And then, of course, and this is just an example, but you had a nice response in the lower ones, and you had a progression in the upper one. So again, another thing that can be used as a supplement or in combination with the biopsies for the target. So with that, I'll just say, I think nuclear medicine, both imaging of what's happening during immune oncology or what is required, you don't have the sampling error, but also the other part of what we're proud of in nuclear medicine, the targeted radionuclide therapy, is really a thing that will facilitate the success of immune oncology. So thank you for the attention. And of course, what I presented, I didn't do. These were the great people doing the things out of our own lab. Thank you so much.
Thank you so much. You're the second speaker with very positive news that is really making leaps in cancer immunotherapy. Because you have to leave and you will not sit at the end there. Maybe, and also we are relaxed now because we have more time. Maybe some questions from the audience, one or two. Short questions, not too long.
I have a question. Can you hear me?
Yes, I can.
Okay. My question is, when you mentioned that systemic radionuclide therapy can be the way to get tumors to become hot all over, not just by external beam radiotherapy. Did you take into account that you are also irradiating passerby lymphocytes in the circulation, and therefore you are causing significant systemic damage to the immune system?
Yeah, it's extremely good question, and that's all about the balance, because you could also kind of harm more than you do good. I think what I didn't say is that the targeted radionuclide therapy is not targeted towards the immune system. So it's totally different targets. That could be somatostatin receptors, or it could be PSMA. And then, of course, you also get some whole body radiation, but you still get primarily to the tumor, and you're not irradiating the immune system. And that was my fault. I didn't explain that it's not the same targets that are used for the radionuclide therapy.
But even in this case, you think that there is no substantial detrimental effect on lymphocytes?
No, the balance is towards that you get a more efficient response.
I just wonder about the availability of the isotope used.
About the
availability?
Yes, I think that's true. It has become, and the
can
question
you repeat,
was, sorry,
can you
I
repeat the
question? That's easier than getting the
question?
microphone in there. The question was about isotope availability. And it's true that nowadays, if you pitch a new project with nuclear medicine, one of the slides would be, where would you source the radionuclides from? I think what we have seen, and I have slides with thumbs up and down on the different tracers, I think, first of all, we learned also from the lutetium-labeled radionuclide therapies that Novartis now has as approved drugs, that once there's a viable business model and a need for it, it will come. And a lot of the tracers is just a question of investment. Some of the tracers have starting material that is scarce and that came from countries that we are not trading with right now. But some of them are also cyclotron produced linear accelerator and do not have starting material that is scarce. So it's merely a question of investing. That's the first answer. And the second answer to it is that we right now see that everybody uses lutetium-177 for therapy. And if they go alpha, they use 225 actinium. There are many other isotopes. And I think the next way we'll see is that it will be much more diverse and also largely depend on the sourcing capabilities. So I don't think it will become a bottleneck. I know it has been in the short term for some of the early drugs.
Thank you so much and wish you a safe trip.
Thank you.
Thank you.